Now, my favourite test. It's great. It looks at the body in all 3 dimensions. It measures balance and proprioception, as I've already said. It looks at also strength, looks at flexibility, looks at someone's motor planning and motor control ability. The reason we created the mat too. So it's the reason I'm standing here today. So I think it's got a lot to be responsible for and a lot of value it's going to add to your clinic. So I think there's only, 2 or 3 people using this in their practice? Yeah, not many. So the people who are using it, Simone, what do you use it for?
So we use it at a football level to predict hamstring injuries as well as other parts of the body.
Cool. So we just so to predict hamstring injuries, we've got to be careful with that word prediction again to know if there's an increased potential risk of injury. And there is some relationship, to hamstring strains. There's also risks, as we'll talk about later if we look at the research, to several other conditions as well. So it's a really useful test. Now, I'm going to pick on another volunteer. Sophie, do you mind being a volunteer for this test? All right, so how do we perform this test? So you have the patient stand in exactly the same position we did for that last weight-bearing lunge position. So what was that, Sophie? Do you remember?
Yeah,
So second toe straight along the centre measurement line, centre of the heel at the other end of that line.
Is my other foot the same?
Yep, so your other foot, you're actually going to place your hands on your hips and you're just going to adopt a single leg balance position to start. Okay. I'll often just start at the other end of the mat and I'll just mirror the patient or client. Okay, and I'll just tell them what they should be doing. All right, so with this test, I want you to reach forward as far as you can along the centre measurement line. Okay, you're going to keep your foot within 1 to 2 centimetres of the mat and return to the start position. Now, our patients and clients are allowed to put a little tap down onto the mat as long as they don't shift their weight onto the mat. If they shift their weight onto there or put too much pressure down or slide along the mat, it won't count. We'll need to restart the test. Likewise, if as they're coming back, they lose their balance, again, that won't count and we'll have to restart the test. The other things we need to look for is that the hands maintain on the hips. So if they come off, again, it's not going to be as reliable. And again, same as the weight-bearing lunge, if their heel lifts off the ground, the test won't be reliable and accurate as well. Okay, so our cues to the patient are reach straight along the measurement line, keeping your foot within 1 to 2 centimetres with a little tap, making sure that the heel stays on the ground. And I try not to give the patient any more cues than that. All right, less cues the better. I'm not telling them what I want them doing with their ankle or with their knees or their hips. I just want to see, how they go about getting this task done. All right. So we're going to have Sophie. We're going to perform 3 to 4 reaches of this test, and we're going to take the furthest measurement, okay, to the most distal aspect of the foot. All right. So if we have Sophie reach forward, you're going to perform 3 to 4 reaches right along over this line here. Good, and back, and again. Good. So we're getting to about 50 centimetres, and again. So making sure same with all the tests, making sure you look from the front, you look from the side, and you look from behind as well, because you're going to get extra information there. So remember, quality is still the most important thing, but we're also getting some nice objective data to give it context, as well as objective data to then go back to the literature and see what that says and make some clinical decisions based off that too.
Just with that,
okay.
Are you allowing them to rest their foot after each go? Or do they have to
Yeah, so they're allowed to come back and they're allowed to put the foot down in between, as long as it's a control, they're not losing their balance to do that. All right? So we're not testing their sort of single balance, we're testing the ability to get out there, transform their energy, and come back to the starting position. Again, I'm not giving them any cues to what to do with their knee. Some people will use a big knee dominant strategy. Other people you see won't bend their knee at all. They'll start to use a hip dominant strategy. And this is the qualitative information that we'll write down, next to the number, just to give it more meaning and more context. Because what you might see is on one side, someone does a really hip dominant reach, versus on the other side they use a really big knee dominant reach. And all of a sudden that says, hey, there's something going on here. So even though they've reached the same distance, the quality of the movement, how they're getting it done, is quite differently side to side.
That might be an opportunity then, after you have observed, without cueing too much, that maybe you do just ask them, okay, well, maybe, why don't you try on that one that's a bit more of the hip dominant, try with the knee bent a little bit more, and maybe that's then the thing that brings on a lot of their symptomatology. So obviously observe first, collect your information, and then you can maybe start to manipulate the movement a little bit.
So we end up performing 8 reaches. So traditionally this test we reach anterior and posterior. We reach medial, and medial is to the inside of the foot once we adopt a single leg balance position. Lateral is to the outside of the foot, reaching behind the leg for the lateral movement. Okay, so across the leg and behind is lateral, and then a combination of those movements. We do an anteromedial reach and an anterolateral reach, and a posteromedial reach and a posterolateral reach. So by the end of it, we have, full 360-degree, view of the patient's, control, balance, proprioception, flexibility in all three dimensions, so we can then compare to the other side. Okay. So how do we use the mat? Does anyone want to have a guess where you put the foot, the right foot for a anteromedial reach?
Is it right leg?
So we'll do the right leg. So you're just saying here and do this. Great, yeah, you're on it, perfect. So you put your foot on the yellow line here. So you have the patient perform for their right leg anteromedial reach. You'll have the second toe, or any of the other reaches forward. You'll have the second toe along this 45-degree line on the yellow aspect there. Second toe behind this orange line, or this 45 to 135-degree line, and then reaching right along the centre measurement line again. All right, so every reach will be over that centre measurement line. All right. Now the leg that we're testing, it's a good point to bring that up, is the leg that we're standing on, not the leg we're reaching with. So this would be a right anteromedial reach because we're testing the right stance leg. Do you want to give that a go, Sophie? So again, the centre of the heel then is at the centre aspect of this 135-degree yellow line as well. And then hands on the hips, reaching straight along that centre measurement line. We're coming over the top and we're having a look at about 54 centimetres. Again, we'll perform 3 to 4 reaches and then we'll compare to the other side. All right, so if you were to do the other leg, Sophie, for anteromedial reach, you'll place your second toe along the orange line this time, centre of the heel at the other end of that orange 135-degree line, and reaching along the mat as far as you can.
And you're just recording the highest measurement.
Great. Yeah, so you're taking the furthest measurement that you can. All right, for each of those. Some studies do use an average of those, but we find, from the research, it does show that the furthest distance reliable, and clinically, it's much more applicable rather than me getting the calculator out or trying to do some, little maths in my head. We get a more accurate representation just with the distal aspect, because that's what you're looking for. You're looking for how far, what's their full capacity, to control that movement. So that was great.
The other thing is as well, there's obviously that learning effect to movement, right? So initially it's going to be a little bit difficult. As you start to, get used to the movement, they're going to find that maximal reach toward the end of that 3 to 4 reaches.
All right, and so then an anterolateral would be just the opposite of what we did, okay? So this time you'll have the left foot for a left leg anterolateral reach on this yellow line, and you'll reach over in front. And then obviously for the right, we then just move to the other side, because anterior is always where the foot's pointing. So this would be anterior if I was reaching straight here. So this becomes anterolateral if I'm sort of reaching over in front of the leg to that lateral aspect. Now, can I just borrow a mat assessment sheet? So you'll notice we've got 2 sort of stars here. All right. And so what we'll see is, you'll see this is the left leg obviously on the left, and this is the right. And what we want to do is, by the end of our assessment, have a picture that looks something like this. All right, so a full 360-degree map of our patient or client's function. Now, if we're not sure which reach we're doing, this is a good tip as you start to learn it with your, before you start to implement with your patients and clients, and for today. So if I'm measuring the right leg, I'm going to get this right star, and I'm going to put it straight down on the ground with the anterior line facing straight where my foot is, all right? Because that's going to be anterior. And so if I'm not sure which reach I'm doing, this will then tell me if anterior is always where my foot's going, this is an anteromedial reach, okay? Likewise, if I was to then put my right foot here, the anterior line would be pointing straight down that way. So this would then be a posteromedial reach. All right, so getting onto those posterior reaches, with the posterior reach, it's exactly the opposite to what we did at the anterior. So the centre of the heel this time is behind the 90-degree line, with the second toe at the other end of that centre measurement line, and we're reaching backwards there. You're doing a great job, Sophie. I'll let you do it again.
No matter which foot I do?
That doesn't matter, that's fine. So second toe along that 180 degree or centre measurement line, hands on your hips, and then reaching backwards as far as you can. Always trying to cue them to lead with their toes. That way you're going to get, you're not going to get just the lateral aspect of the foot or a different aspect which could change. You'll have that most distal aspect of the reaching part of the body, and that'll be the same for all the reaches. So that would be a posterior reach. If we then get Sophie to place her foot along this this yellow line to the left, and then with her second toe along the 135, the heel behind that orange 135 to 45, reaching that way, what reach would this be? Yeah, so it'd be a left leg, posteromedial. Awesome, nice. And then again, the opposite would then be on the orange line, heel behind the yellow 135 degree line, and this would be a left leg posterolateral. Okay, so they're quite simple. Take a little bit to get your head around. That's why I really recommend using those sheets to start with, because that'll really help you with the learning. The different ones though are the medial and the lateral reaches. Okay, so we're going to use the navicular tubercle on the inside of the foot in the centre of the star, with the medial aspect of the foot behind the 90 degree red start line. Okay, you'll then place your hands on your hips and then reach along the mat as far as you can. Again, a light touch is okay, or staying within 2 centimetres of the mat, and returning to the start position. Okay, so that would be a medial reach. Obviously, if I switched around, it would just be in this direction. And if I was doing a lateral reach, I'll use the styloid process on the lateral aspect of the foot, of the fifth met, and then reach posterior to the leg, or behind the leg, as far as I can along that measurement line, and return to the start position. And so by the time we do that, we have a diagram, something like this one from Zhang et al. In 2014. So this was a study that they did in regards to actually an older falls population. Okay, and so what they did is they set up some baseline measurements, which is this dotted red line, and then put an intervention into place, which was just a general strength and conditioning program, just some sort of lightish sort of weights, I think 10 to 12 reps, a few times a week for 3 months, and a Tai Chi program. 3 times a week. And what they found is in that population, they were 4 to 5 times less likely to have a fall in that group compared to this blue control group, which didn't improve, with obviously because there was no intervention. All right, and so that's a nice way how you can visually represent what's happening with your patients or your clients, and you can show them progress over time as well.